Good morning, everyone. My name is Jamie De La Fuente. I'm one of the second-year Mayo Gastroenterology Fellows, along with the rest of my Mayo Clinic Rochester team. In conjunction with my mentor, Dr. Shonik Majumdar, we're glad to be presenting this abstract presentation. So, acute pancreatitis with intraductal papillary mucinous neoplasms recurs infrequently after surgical resection. So on the background, acute pancreatitis, or AP, is a worrisome clinical feature in individuals with intraductal papillary mucinous neoplasms, or IPMNs. It's been discussed in several national and international guidelines about how acute pancreatitis may be a consideration for surgery for relief of symptoms in select individuals. Unfortunately, limited data on acute pancreatitis recurrence after IPMN resection currently exists. The aims of this abstract presentation are threefold. One, to describe the incidence and recurrence rates of acute pancreatitis in individuals with IPMNs. To identify post-operative recurrence rates of AP in surgically resected IPMNs. And lastly, to estimate surgical morbidity and mortality in this cohort. So this abstract presentation involved retrospective single tertiary referral center cohort. It involved adults with surgically resected IPMNs to ensure appropriate pathology, and this took place between the years of 2000 and 2015. Preoperative history of acute pancreatitis used revised Atlanta classification. Clinical, pathologic, and imaging data were manually abstracted to ensure that acute pancreatitis criteria had appropriately been met, and alternative causes of AP weren't inappropriately included in this study. Outcomes including surgical complications and recurrent acute pancreatitis, were also manually abstracted. Within the results, of the 453 subjects with surgically resected IPMNs at our institution, 96 subjects met inclusion criteria. 2 individuals were excluded as they were found to have gallstone pancreatitis. And here in table 1, you can see episodes of acute pancreatitis prior to IPMN resection, with 17% of individuals having 1 episode of acute pancreatitis prior to IPMN resection, with the rest of the individuals having at least 2 episodes or more of acute pancreatitis. Here in this horizontal bar graph, you can see the surgical pathology of those with acute pancreatitis prior to IPMN resection. The minority of patients had cancer high-grade dysplasia, where the majority of patients had surgical pathology showing low-grade dysplasia in the IPMN. There were no post-operative deaths in this cohort. Morbidity involved 27 patients, or 29% of the cohort, and this was primarily because of prolonged hospitalization defined by at least 2 weeks in the hospital. So 13 subjects were lost to close follow-up. Of the remaining 81 subjects, there was a median follow-up of 6.37 years. Recurrence of AP occurred in 10 subjects within a median of 2.8 years. In conclusion, in our cohort, about 20% of IPMN resected individuals had AP prior or at the time of diagnosis. These episodes of AP were without alternative cause. So post-operative recurrence of AP was uncommon, demonstrated in 12% of individuals. Most AP recurrence occurs in the first 2.5 years. So hopefully, with this abstract presentation, it will provide some guidance for clinicians when discussing and counseling patients on what to expect with the occurrence of AP post-IPMN resection. Thank you very much for taking the time to listen to my presentation, and I hope you enjoy the rest of the virtual APA. If there's any questions, feel free to contact me at the email address on the screen. Thank you again.